Good afternoon, everybody. I'm Dr. Pratik Kamble, Chairperson for the Amounts Endocrinology Committee. A warm welcome to the Experience series. If this is the first time you've logged in, we tackle a lot of mother and child healthcare related issues. And today's event is on preterm labor, protecting the at-risk fetus. We have a galaxy of stalwarts who are here for today's program. But before we begin, as is usual, I'd like to pay my respects to the Amounts office bearers. Next slide, please. Our beloved President, Dr. Rajendra Singh Pardeshi, sir. Sir is the president of AMOGS. He's supported us in a lot of our endeavors and our academic endeavors throughout the past few years. Thank you so much, sir, for your blessings and your guidance always. Next slide, please. I'd also like to acknowledge Dr. Sujata Devi, who is the secretary of AMOGS. She is also an office bearer of the Mumbai Society, and she is the Joint Associate Editor of the Journal of OBGYN of India. Thank you, ma'am, for your support and your blessings. Next slide, please. I'd also like to acknowledge the ICOG office bearers, Dr. Rashmi, who's the chairperson of ICOG. Next slide, please. And Dr. Ashok Kumar, who's the secretary of ICOG. Thank you for the ICOG credit points, not only for this program, but also for all the programs that we've done in the past. We have two eminent stalwarts as chairpersons today, Dr. Sagar Kataria and Dr. Mala Srivastav. Dr. Sagar Kataria, next slide please, is a zonal coordinator of AMOGS, and he's always been there for us whenever we've requested his presence. He's somebody who we look up to. He's very fit and athletic, something which I try and do, but I'm never able to reach his level of perfection. Sir has very recently organized a fantastic two-day conference in Satara. He is the zonal coordinator, as I mentioned, for Zone 2, organizing chairperson for the annual conference of AMOGS held in Mahabaleshwar in 2019, past president and secretary of Satara OBGYN Society, a much respected teacher at the district hospital in Satara. Thank you so much, sir, for joining us. Next slide, please. We have with us Dr. Mala Srivastav. She's a past president of the AOGD, and she's the vice president-elect of ISOPAB. She is the head of unit of oncology at Gripmer, and she has various accomplishments, including being a gynae robotic and an endoscopic surgery at Sir Gangaram. She's a governing council member of ICOJ, and we will welcome her inputs for today's two speakers. The first speaker is none other than Dr. Rashmi Kahar. She's the chair for the High-Risk Pregnancy Committee of AMOGS. And later on, we'll be joined by Dr. Shyam Desai, sir, past president of Mumbai Society and Foxy as well. Today, we are debating preterm labor and how we can protect the at-risk fetus. I'd like to place on record my gratitude to all the faculty, to AMOGS for giving us this platform, to Science Integra, and of course, our education partners, Blissin, who have been with us from the beginning of the Experience series this year. With that, I will hand over to the chairpersons. I request Dr. Sagar Kataria, sir, to introduce our first speaker, Dr. Rashmi. Next slide, please. Sir, you're muted. Please unmute.
Good afternoon, everyone. Next slide, please. It's my pleasure to be here in this experience series of AMOGS Endocrinology Committee. And the topic for today's session is preterm labor, protecting the high-risk fetus. Let me introduce Dr. Rashmi Kahar. Rashmi Kahar is chair of AMOGS High Risk Pregnancy Committee at present, and I have witnessed her AMOGS 2020 with much enthusiasm, and she was a very good host at AMOGS 2020 at Amravati. She's always a dynamic and very active member of AMOGS, and she's seen all over various conferences and various webinars. Let me present to you Dr. Rashmi Kahar. The screen is yours, Rashmi.
Thank you very much, sir.
I take this opportunity to welcome Dr. Shyam Desai, sir. He has been a mentor, icon, and past Foxy president. Welcome, sir.
A very good afternoon, respected seniors and dear friends. Thank you, Dr. Pratik Tambe, sir, for including me in this prestigious experience series. Dr. Pratik Tambe, as we call, a great academician of our times. So it's a great honor to be here. My great respect and pranam to the teacher of teachers, Dr. Shyam Desai, sir. So please accept my pranam. My regards and respects to the amongst chairs, Dr. Pardeshi sir, Dr. Sujata madam, Dr. Lakshmi madam, Dr. Ashok Kumar sir, and I'm especially thankful to the chairperson, Dr. Sagar Kataria sir, and Dr. Mala Srivastava madam, and thank you Sagar sir for the very kind introduction. So, friends, as we all agree, preterm labor is defined as one, where the labor starts before 37 completed weeks of gestation. That is exactly 259 days if we calculate it from the first day of the last menstrual period. It is a condition of a great, which takes great toll on the healthcare system of our country. And it majorly affects not only medical problems, but also has major implications at the level of social, economical, and emotional health of the patients and the relatives of the patients, families of the patient. So what is the magnitude of this problem? So as we all agree that we have around 50 million preterm births every year. 1 million deaths are reported in children who are below 5 years in 2015, and worldwide rate of preterm birth is almost about 5 to 18%. And our country tops first 10 countries with 60% of the world's preterm births. So as we look at this diagram, and if we go retrospectively from below upwards, we will notice that as the gestational age at the birth go on decreasing, the chances of survival of the fetus also go on decreasing. And now with the advances in the treatments and medicines, we have been able to save the fetuses in the extreme prematurity group also. That ranges between the 21 weeks to 25 weeks. It has been demarcated by this green line. So to deliver a fetus at the threshold of the viability, that is 23 to 24 weeks, is a real medical and ethical challenge. But now we have a universal consensus that after 25 weeks of gestation, we should do active management to save these babies. And we have already recently noticed that there is a marked improvement in the extreme neonatal birth survival rate, but same we can't say yet about the composite neonatal morbidities and mortalities associated with this extreme prematurity. So what are the factors that are going to influence preterm labor? So the majority of the preterm labor is going to affect it if the patient is having a history of previous preterm birth. If the previous preterm birth had been spontaneous or induced, the important aspect is if the previous spontaneous birth was without any intervention. And there are many genetic, racial, age factors, cervical surgeries history, along with uterine anomalies, maybe congenital, acquired with or without interventions. There could be the histories of chronic medical disorders, previous histories of sudden infant death syndromes. There may be the artificial reproductive techniques and the results affecting the time of the delivery of the fetuses, high order pregnancies, short cervix, infections, including reproductive tract infections, periodontal infections, asymptomatic bacteria. And some behavioral factors also affect the preterm labor, like the short delivery interval, occupation of the patient, weight, exercises, smoking, substance abuse, diet, stress, and maybe suboptimal perinatal care. And how does preterm birth affect a neonate? There are lots of millions of uncountable neonatal deaths due to prematurity. Along with that, we have issues of intraventricular hemorrhages, seizures, necrotizing enterocolitis, and persistent pulmonary hypertension. The neonates may have hypoxic ischemic encephalopathy, bronchopulmonary dysplasia. There may be sepsis, maybe of the origin of the sepsis may be lot of type, like maybe bacterial or other superadded or nosocomial infections. The children may have physical and cognitive disorders, cerebral palsies, learning deficits, and learning disorders. So, and why there is such high magnitude of this preterm births? Why? Because basically we do not have any effective screening technique so that we can identify high-risk patients and do something to prevent the preterm births. Neither do we have any perfect or guideline strategy to intervene and prevent it. So friends, let me tell you, one fine afternoon, Dr. Pratik Sambasari called me and said, "Comrade, you have to talk on preterm labor. Let me know what's in your armamentarium." And I said, "Sarkar, I have this ultrasound measurement of cervical length, which can help me to predict and prevent. I have some biochemical markers. I have some tocolytics. I have progesterone therapy. I have corticosteroids, and I have maxil therapy for neuroprotection that I can talk about." So let us talk about this ultrasound measurement of cervical length. As we know that we can assess the cervical length digitally, transabdominally, transvaginal by transvaginal sonography or by translabial sonography. And we understand the cervix is such a dynamic structure and it shortens as the gestational age advances. Cervical shortening leads to labor. The effacement starts at the internal os and it progresses accordingly. So mean cervical length is 42 millimeter at 11 to 14 weeks of gestation and 38 millimeter at 22 weeks of gestation. And this is the scanning representation of a TVS measurement of cervical length. So TVS measurement of cervical length, as we all understand, is a gold standard measurement for the prediction of cervical length, or is the deciding factor for the cervical length measurement. So it is measured at the linear distance between the triangular area of ecodensity at the external os and the notch at the internal os. We have to take 3 images and use the shortest distance and the best distance possible for the cervical length. We also have to check at this point of time if there is any presence of funneling. Funneling, which is a dilatation of the internal os, but it is not an independent risk factor to decide if the patient is going to land in preterm labor. At this level, also check for amniotic fluid sludge, which is a cytogenic aggregates within the funnel, and we can say that it is an independent risk factor for preterm labor. Short cervix, that is cervix length less than 25 millimeter before 24 weeks of gestation, is a strong predictor for spontaneous preterm labor. So are there any guidelines for this TVS screening of cervical length? So these different societies, they have varied opinions for universal screening by cervical length measurement. Are we going to advise in all patients of ours measurement of TVS cervical length so that we can predict if the particular patient is going into the preterm labor or not? But let me tell you, we do not have mandate of any such kind for all the patients. Yes, but in high-risk patients, like those patients who have the history of prior preterm births, they have the multiple pregnancies, we can scan, give extra 5 minutes and measure cervical length every 2 weeks between 16 to 24 weeks. And do we have any new modalities for prediction of preterm labor? Yes. We have some important things like cervical elastography. We also have measurement of cervical consistency index, and we can also measure uterocervical angle in the second trimester, that's between the angle between the lower uterine segment and the cervical canal. If it's more than 105 degrees, it is significant and a strong predictor of preterm labor. So the key points here are the TVS measurement, transvaginal sonographic measurement of cervical length. It's very sensitive and it is an ideal technique. 25 millimeter cervical length is the threshold defining the short cervix. Short cervix in 14 to 24 weeks is a strong predictor of preterm labor, and we do not have any mandate for universal screening of these patients with cervical length measurement. And to help us, there are some biochemical markers also. They can help us in predicting preterm labor, and they are majorly they are fetal fibronectin, estriols, corticotropin-releasing hormone, beta-SCG levels, and alpha-fetoproteins. The important most is the fetal fibronectin. If it's observed in the vaginal fluid in the late second or early third trimester of the pregnancies, it is having a very good negative predictive value. If it's not found in the cervical swab, then we can say that the patient is not going to go into any preterm labor, and there is no need of any aggressive intervention or treatment of the patient. So now then, after so we have, I think, the last decade we have been continuously talking about the progesterone. I think the only molecule we have been most experimented and talked about is progesterone, and in various forms we have been using it for the management of recurrent pregnancy losses or spontaneous second trimester abortions. So because it helps, progesterone hormone, as we all agree, helps into the continuation of pregnancy. So one finding in 2003, research a paper was published in the by the National Institute of Child Health, and it was a double-blind placebo-controlled study. And the patients who were assessed whether those with the history of preterm labor and within the 16 to 20 weeks of gestation. And what happened that this study showed, and they used 17-hydroxycaproate progesterone, weekly injections. And the study clearly and conclusively said that weekly injections of 17-hydroxyprogesterone caproate resulted in substantial reduction in the rate of preterm deliveries among women who were at particularly high risk for preterm, and reduced the likelihood of several complications in their infant. So it was 2003, and from this data published, started various trials and more studies about the use of progesterone in the preterm labor. So the next study came in 2007, and it was a randomized controlled trial, again double-blind placebo-controlled randomized trial. And progesterone vaginal gel was used for the reduction of recurrent preterm births. And but this trial failed to show any use of prophylactic treatment with the vaginal progesterone, and it clearly said that it does not affect or does not reduce the frequency of recurrent preterm birth. So the next trial came in 2007 only, and it studied the progesterone and the risk of preterm birth amongst the women with a short cervix. And what it said, see, again, it said the women with the short cervix treatment with progesterone reduces the rate of early preterm delivery. The next important study was a very awaited optimum study published in Lancet. It was 2016, and lots of people were just looking at this study, what the study Lancet study is going to say. But again, it failed to say that there is clear-cut evidence of progesterone's use in the management of preterm labor. It said that vaginal progesterone was not associated with reduced risk of preterm birth or composite neonatal adverse outcome, and showed that there are no long-term benefits or harms on outcomes in children of 2 years of age. And then a Society of Maternal Fetal Medicine published their study in 2017. They studied 17-hydroxycaproate, and yes, they said they confirmed that in women with a single time gestation and history of prior spontaneous preterm birth between 20 to 36 weeks of gestation, they surely and very clear-cut recommended 17-hydroxycaproate progesterone at 250 milligram intramuscularly weekly, starting at 16 to 20 weeks of gestation and 36 weeks of gestation or delivery. And they also said that vaginal progesterone should not be considered as a substitute for 17-hydroxyprogesterone in this patient. And there was a study of progesterone used in prevention of preterm labor in multiple pregnancies also. So it clearly said that routine administration from 24 weeks, it doesn't show any reduced risk with the use of progesterone. In multiple pregnancies with short cervix, progesterone use has not been significantly reducing the risk of preterm birth. To add to the problem, we have this debate of injuries, the heartthrob debate of all the OBGYN conferences, cervical cerclage versus progesterone. But yes, in NICE guidelines 2016 says that cerclage and progesterone are recommended if there is a previous history of preterm birth, cervical length less than 25 millimeter, and the gestation of the fetus is 16 to 24 weeks. But yes, the New Zealand guidelines, RANSCOG 2017, recommended only progesterone use, and they said that we should not use more interventions, surgical interventions like cervical in cerclage to minimize any adverse effect on the babies. So now after the progesterone comes a major discussion about the tocolytics. Please forget the word ARDS. It's ARDS written in the first line. It's a mistake, printing mistake. So do you agree to tocolysis for management of preterm labor? We all agree that tocolysis slows down. It inhibits the contraction of the uterus. Thereby, it can help in arresting preterm labor. We have a good 5-6 groups of classes of tocolytics like the beta mimetics, calcium channel blockers. We have Maxwell tried and tested. We have oxygen receptor and blockers. We have prostaglandin inhibitors. We have nitrates and others. So beta mimetics for the use of tocolysis are comes with a set of major complications like cardiac arrhythmias, hypertension, hyperglycemia, and majorly pulmonary edema. So beta mimetics, though we know that some people are using it, we're using it in various type of formulation, it's a complete no-no for the tocolysis in preterm labor. And the nitrate group also we do not recommend for tocolysis in preterm labor because sometimes the interventional scientists use it for the intrauterine procedures, but it causes cervical dilatation. So the nitrates are also a big no-no when it comes to the tocolysis in preterm labor. So we have these calcium channel blockers, tried and trusted, magnesium sulfate, oxygen receptor blockers, and sometimes prostaglandin inhibitors if we need. So basically, what is the aim of tocolysis in preterm labor? The primary aim of tocolysis in preterm labor is we only have to buy time. We only have to buy time for administration of a complete antenatal dose of corticosteroid so that we can reduce the severity of acute respiratory distress syndrome and we can facilitate the in utero transfer to neonatal care facility. And the secondary aim is if we have to delay the delivery to prevent the neonatal complications if there is a severe case of prematurity. So NICE guidelines also say that we have to consider nifedipine for tocolysis for women between 24 to 25 weeks pregnancy who have intact membranes and are in suspected preterm labor. We can offer nifedipine for tocolysis in women between 26 to 33 weeks actually pregnancy who have intact members and they are suspected or diagnosed preterm labor. And if nifedipine is contraindicated for some reasons, we can shift over to oxytocin receptor antagonists. We do not offer beta mimetics for tocolysis. And the loading dose is 20 milligram orally. As we all know, it has to be followed by 20 milligram 3 to 4 times daily and has to be adjusted according to the uterine activity. And let me add here one line that we are using nifedipine only in oral formulations and never in any other formulations like sublingual. And this is the new kid on the block, and it is the atosiban, as we all know, it is the oxygen antagonist. The advantages are that it acts only on the myometrium, and it comes 1 ml that is 6.75 milligram, and in 5 ml that is 37.5 milligram, and it has to be given in a particularly scheduled dose, and it is the safest type of tocolysis nowadays in preterm labor. So what is the what should be the next topic of discussion? Preterm labor, and it is the panacea in the management of preterm labor, and it is the administration of antenatal corticosteroid, which can be used, which we use to reduce the neonatal morbidity and mortality. And the RCUG guidelines also supplement and strongly advocates the use of antenatal corticosteroids to reduce the neonatal mortality and morbidity. So the guidelines, the NICE guideline supplement and Green Top also says that they have these key recommendations. The first point is a course of antenatal corticosteroids given within the 7 days prior to preterm birth. It reduces perinatal and neonatal death and respiratory distress syndrome. There is a second point also, which I will be talking a little later on. The third point is corticosteroids should be offered to women between 24 to 34 weeks of gestation in whom imminent preterm birth is anticipated. Women with twins and triplets should also be offered targeted antenatal corticosteroids for early birth in line with recommendations for singletons. Birth should not be delayed for antenatal corticosteroids if the indication for birth is impacting the health of the woman or her baby. Antenatal corticosteroids should be offered to women with PPR who are at risk of preterm birth. Antenatal corticosteroids use reduces neonatal death when the first dose is given within the 48 hours or prior to birth. And benefits are also seen when the first dose is given within 24 hours of birth, and antenatal corticosteroid should be given if birth is expected within this time. So our neonatologists also recommend the use of antenatal corticosteroid. It has been so much so recommended that the government of India has also accepted the use of antenatal corticosteroids in preterm labor to the point, to the limit that the A&M workers, they are also getting trained so that they can at their level give a dose of antenatal corticosteroids in patients who are in preterm labor. So why injection beta? So as we all know, we can use either dexamethasone or betamethasone. We prefer dexamethasone in our country because we know that it is listed in the 2 essential medicines list. It is inexpensive and it is widely available in India, in our country. The salt, betamethasone, acetate, and phosphates, and with dexamethasone, we can say that it's very appropriate option. It is very much recommended. Administration of antenatal corticosteroid and dexamethasone constitutes an integral part of the standard treatment of preterm labor now in our country. And of course, we are not supposed to use any oral medications, and repeated courses or more frequent doses are also not at all useful. And multiple courses, in fact, could have caused some detrimental effects in the fetuses. So multiple or repeated doses are a complete no-no. And NSAIDs, they have a role. Antenatal corticosteroids actually have a role if even the fetus has been receiving surfactant therapy, if it is available. Then also there is a positive role of antenatal corticosteroid. So as we all know, this is a dexamethasone sodium phosphate. It is available in 4 mg per ml strength, and we have to give 6 mg for 4 injections 12 hours apart. We have to give it deep intramuscularly, preferably at the anterolateral aspect of the thigh. The complete course will have 4 doses that equivalents to 24 mg total. And the advantage is that we do not need any special facility for storage of this drug. So as we are talking about the corticosteroids, so we have this action trial by WHO. Actually, it is and it strongly recommends the use of a corticosteroid. But as we are talking about the corticosteroid, there has to be a mention of this ACT trial, and it was a population-based multifaceted strategy, and they observed that strategy, and they interpreted that there was despite the increased use of antenatal corticosteroids in low birth weight infants, it did not decrease any number of neonatal deaths. And they also observed that there was some risk of infection which was increased. And also we had this 2020, it's a very recent JAMA study. And they said that there was association, they studied the association between maternal antenatal corticosteroid treatment and mental and behavioral disorders in children. And that was a population-based cohort study. And yeah, actually at this time, at this point of time, I would like to say that we have to use very judiciously. We have to be very judicious in the use of antenatal corticosteroids, and we also have to agree to the fact that the concerns about the behavioral or disorders of the learning disabilities which are occurring after the use of corticosteroids, they may be due to the prematurity of the babies itself. And then comes the MAXUP regime for the neuroprotection I won't be talking about because we have our great teacher talking about it after this talk. And there are some recommendations. I would like to go through them. Antibiotic administration is recommended for women with preterm pre-labor rupture of membrane. The tried-tested antibiotic is erythromycin. It is recommended as the antibiotic of choice for prophylaxis in women with preterm pre-labor rupture of membranes. Kangaroo mother care is recommended for routine care of newborns which are weighing less than 2,000 grams at birth. And the indication for the cesarean section for preterm labor birth has to be essentially obstetric. So there are some points in the to be observed in the intrapartum management, during the intrapartum management of preterm labor also. The intrapartum continuous fetal heart rate monitoring is essential at the time of delivery of a preterm infant. Keeping the membranes intact has been said that it is very helpful during the delivery of the fetus. The choice of anesthesia and gestation of the fetus is it is not any related factor. And oxytocin is safe if the augmentation is needed. Episiotomy does not provide any advantages in preterm labor, but yes, a very good perineal support and just a widening of the introitus and very good support to the head of the baby will go long term in saving the baby. And we recommend delayed cord clamping, and we also recommend holding the fetus at a lower level than cord at the delivery. So the key points are the limit of the fetal viability is decreased, and it is 25 weeks onwards. And 25 weeks onwards, we should be able to offer active management to save the preterm babies. The most challenging time is 23 to 24 weeks window, with fetuses of 500 to 600 grams of birth weight. And basically, to save a preterm birth and to save the baby further, it is a teamwork. It is a teamwork between the consultant and the pediatrician, the anesthesiologist, and what is important is the counseling of the patients, addressing their apprehension, the counseling of the family and the relatives, and also there are multiple factors which would affect, like what would be the estimated fetal weight, what is the USG finding, what are the USG finding, how the patients are going to continue the care because the baby is going to need special facilities, and what was the birth weight at the time of the delivery, what are the resuscitation measures undertaken. These are all vital factors, and it's very important that we should have our own guidelines so that we have 1, 2, 3, 4 clear-cut idea how we are going to treat a patient in a preterm labor. And what I learned when I was reading about the preterm labor, the short cervix, which is, we can say, less than 25 millimeter on TVS with the previous history of spontaneous labor is very important. Tocolysis has to be used only for buying time so that we can completely administer the dose of antenatal corticosteroid therapy or for buying time for in utero transfers. The corticosteroids has to be used very judiciously, and education of healthcare workers about the use of antibiotics, about the use of speculum examination, about the digital vaginal examination, about the sterile speculum examinations, I want to say, and sterile digital vaginal examination, need of the hour. And yes, again, we should have our own guidelines. So this is something, I think this is what I could say. This is all evidence-based and best scientific evidence and we could get from for this topic. And जो भी बोलेगा evidence के साथ ही बोलेगा, otherwise कुछ नहीं बोलेगा. This is Amox tagline. And thank you, Pratik bro. It's a wonderful opportunity, and thanks a lot. It's a great honor actually to be with you today.
Thank you, Rashmi. It was a wonderful presentation, in-depth presentation. You have quoted many studies, the fallacies of few treatments we are using, and the benefits of few treatments that we are using. In spite of all this research and developments, preterm labor still remains a dilemma, and there is no definitive treatment, no definitive diagnosis as such, and we are still at the verge of unknown. So what we can do right now is just we can, the best predictor is of course the history of previous preterm labor is the best indicator. And further, we can monitor the cervical length in all the patients, and if there is progressive reduction in cervical length over the NT scan and 20-week scan, then we can provide progestational support. And if the cervical length is short with previous history of preterm labor, we can definitely go for preterm osteotomy. Sorry. So overall, it is still a dilemma, and there is no definitive treatment. Judicious use of all the cervical tightening and progesterones and tocolytics is most important in this preterm labor. Thank you.
I must
Thank you,
congratulate,
Dr. Rashmi.
I must
Yes, ma'am, please
congratulate
go ahead.
Dr. Rashmi for an excellent scientific deliberation. You have comprehensively covered the risk points, the signs and symptoms, how can an obstetrician pick up the cases of preterm labor, and how to judiciously manage these patients in the antenatal period, as well as in the intrapartum, as well as the postpartum period. I must congratulate you for an excellent scientific deliberation.